Hello, my name is Donna Strugarfrich, and I'm a principal with Health Management Associates, and I've been asked to talk with you today about treating opioid addiction in the justice system, particularly in correctional settings of prisons and jails. So HMA, and me in particular, has been working on this issue for 2.5 years. In California, we're working with 32 county jails and teams from their counties. In Pennsylvania, we're working with 12 jails in the prison system. In Michigan, we're working with a handful of jails in the prison system, California prison system as well. I worked with 16 counties around the country for an Arnold Ventures and Bureau of Justice Assistance program. We've done a lot of this. In our California teams, 22 of our teams reported to us recently that through June, they had treated more than 6,500 detainees with medications for addiction treatment behind bars. We've learned a lot, and I want to share with you some of what we've learned and encourage you to put it to work in your communities. So we learned that we have to do this. It's the standard of care, more so every day, and to use medications for addiction treatment that are FDA approved. The National Sheriff's Association and all the major associations representing professionals in the justice system, including drug courts and family courts, all speak to, in their position statements, the need to make all FDA-approved medications available to people in the justice system. And they all say that it must be done in the auspices of a provider-patient relationship. This is not the jurisdiction of a judge, a sheriff, or a probation officer. There have been a string of lawsuits with challenges to compliance with the Americans with Disabilities Act and challenging deliberate indifference of prisons and jails in terminating people from their medications. We just have to do this. It's really not a question about if anymore, it's how. We've also learned that this works best when you can work with more than one jail in a state at a time. The best scenario for an effective and sustainable evidence-based program is multiple jails and the prison system together. And the state opioid response funds are really perfect for funding this. But if you can't do that, anything is better than nothing, and every jail should look at this. We also learned with our many, many jails that even though there's one standard in a state under which, I guess I should say one set of regulations in a state under which methadone treatment providers should work with jails, they are not uniformly applied in states, and it can be very challenging. So that's very tricky. We also saw in the spring with the new clinical guidelines from the American Society for Addiction Medicine, or ASAM, a big game changer for jails. ASAM's new guidelines say in no uncertain terms that acute opioid withdrawal is a clinical emergency for which there is evidence-based care. A person withdrawing from opioids who has a COWS score of greater than 8 should receive agonist treatment. Detox with comfort care, which is the standard in most jails, is not only not evidence-based care, it's actually malpractice. So jails in withdrawing people need to have access to buprenorphine and be able to taper people over several days. This is the emerging standard of care, and it will be the string of it will be central to the future lawsuits that we see. So we also learned that when you get a jail MAT program going, you should feel really good about it, but you should also go back and look at the real numbers. This is not talked about a lot yet out there, but you need to go back and see who the program is treating and not treating. Often, a number of detainees will be evaluated for eligibility for MAT, but nobody gets it, or maybe one or two people do. So we see that there are wide variations in clinical practice across practitioners in a jail. There may be ex-waiver providers who still don't like the idea of using agonists for treating people in jail. You need to look at who's under treating, who's being denied, who's being terminated. as an important part of program integrity. And you also need to look at which detainees are refusing treatment, because there can be gang issues and serious concerns related to that. And lastly, a good, solid, long-standing program needs to look at racial disparities and do some work in their screening and assessment practices there as well. The things we're going to do next in California with our 32 teams are, first of all, address methamphetamine and stimulant use, because now under state opioid response funds for the next 2 years, we're allowed to do that. So we're developing a whole bunch of new stuff on that. And we're also focusing on co-occurring addictions and serious mental illness, which is very important. Most of the people who are in jail with addictions and serious mental illness are only treated for their serious mental illness. And we're developing some new approaches and new content on this, which is super important. Another thing that we learned, which is probably going to be news to you, is that it can be really challenging to keep people on MAT after they leave the jail. Even when a community does all the work to establish treatment, it's not long after the detainee is released that he or she encounters a child welfare worker or a judge or a probation officer who says, yeah, you're on methadone, you're not clean, you can't ABC, you can't be in our drug program, drug court, you can't live in this place, you can't have your children back. So it puts the person who is in fact in stable recovery in a position where they have to decide whether to terminate the medication that's keeping them in stable recovery or not. And what we learned is that that really puts people at risk for overdose, for relapse and overdose and death. And so our SOR program in California started a whole second program around educating all of the professionals in the justice system about opioid use disorder, the medications and its treatment, and specifically by profession, their role in keeping their clients stable by keeping them on their MAT treatment. We've trained over 1,600 people in California. And most importantly for you, we have converted all of our training into web-based modules, and each one has a facilitator's guide with it. And the whole thing was designed so that people could use it outside of California or inside of California to train their own employees. All this material is free and it's on our website. Do not underestimate this issue. California is the only state that's really broadly addressing the public or the professionals in the justice system that often place restrictions or urge their clients to discontinue their MAT. So it's really important to make sure that you're closing the loop on all of the people that are going to have contact with these clients. So in summary, people with addictions in the justice system are a priority population for any community. Treating their addictions in the justice system gives them a chance to recover. And these are people who are suffering from the most advanced addictions. It gives them a chance to recover and get their lives back. It reduces relapse, overdose, and death, and it reduces crime. It can be challenging, but it is essential. Withdrawal management and addiction treatment are clearly defined conditions protected by the Americans with Disabilities Act, and all of the decisions about medications for addiction belong under the authority of healthcare in a correctional setting and in the confines of the patient and prescriber relationship. Opioid use disorder treatment that is in place when a person enters the jail must be continued, and until after release, until the provider and the patient decide to taper it. This takes a village. This saves lives. And I'm going to give you a slide that has information about our Jail MAT project website with some really cool, good, recently done webinars that you may access, and also to all of our training materials for the justice system. Thank you very much for your time today. Go forth and do this work. It saves lives. Hello, my name is Donna Strugarfrich, and I'm a principal with Health Management Associates, and I've been asked to talk with you today about treating opioid addiction in the justice system, particularly in correctional settings of prisons and jails. So HMA, and me in particular, has been working on this issue for 2.5 years. In California, we're working with 32 county jails and teams from their counties. In Pennsylvania, we're working with 12 jails and the prison system. In Michigan, we're working with a handful of jails and the prison system, California prison system as well. I worked with 16 counties around the country for an Arnold Ventures and Bureau of Justice Assistance program. We've done a lot of this. In our California teams, 22 of our teams reported to us recently that through June, they had treated more than 6,500 detainees with medications for addiction treatment behind bars. We've learned a lot, and I want to share with you some of what we've learned and encourage you to put it to work in your communities. So we learned that we have to do this. It's the standard of care, more so every day, and to use medications for addiction treatment that are FDA approved. The National Sheriff's Association and all the major associations representing professionals in the justice system, including drug courts and family courts, all speak to, in their position statements, the need to make all FDA-approved medications available to people in the justice system. And they all say that it must be done in the auspices of a provider-patient relationship. This is not the jurisdiction of a judge, a sheriff, or a probation officer. There have been a string of lawsuits with challenges to compliance with the Americans with Disabilities Act and challenging deliberate indifference of prisons and jails in terminating people from their medications. We just have to do this. It's really not a question about if anymore, it's how. We've also learned that this works best when you can work with more than one jail in a state at a time. The best scenario for an effective and sustainable evidence-based program is multiple jails and the prison system together. And the state opioid response funds are really perfect for funding this. But if you can't do that, anything is better than nothing, and every jail should look at this. We also learned with our many, many jails that even though there's one standard in a state under which, I guess I should say one set of regulations in a state under which methadone treatment providers should work with jails, they are not uniformly applied in states, and it can be very challenging. So that's very tricky. We also saw in the spring with the new clinical guidelines from the American Society for Addiction Medicine, or ASAM, a big game changer for jails. ASAM's new guidelines say in no uncertain terms that acute opioid withdrawal is a clinical emergency for which there is evidence-based care. A person withdrawing from opioids who has a COWS score of greater than 8 should receive agonist treatment. Detox with comfort care, which is the standard in most jails, is not only not evidence-based care, it's actually malpractice. So jails in withdrawing people need to have access to buprenorphine and be able to taper people over several days. This is the emerging standard of care, and it will be the string of it will be central to the future lawsuits that we see. So we also learned that when you get a jail MAT program going, you should feel really good about it, but you should also go back and look at the real numbers. This is not talked about a lot yet out there, but you need to go back and see who the program is treating and not treating. Often, a number of detainees will be evaluated for eligibility for MAT, but nobody gets it, or maybe one or two people do. So we see that there are wide variations in clinical practice across practitioners in a jail. There may be ex-waiver providers who still don't like the idea of using agonists for treating people in jail. You need to look at who's under treating, who's being denied, who's being terminated. as an important part of program integrity. And you also need to look at which detainees are refusing treatment, because there can be gang issues and serious concerns related to that. And lastly, a good, solid, long-standing program needs to look at racial disparities and do some work in their screening and assessment practices there as well. The thing that we're going to do next in California with our 32 teams are, first of all, address methamphetamine and stimulant use, because now under state opioid response funds for the next 2 years, we're allowed to do that. So we're developing a whole bunch of new stuff on that. And we're also focusing on co-occurring addictions and serious mental illness, which is very important. Most of the people who are in jail with addictions and serious mental illness are only treated for their serious mental illness. And we're developing some new approaches and new content on this, which is super important. Another thing that we learned, which is probably going to be news to you, is that it can be really challenging to keep people on MAT after they leave the jail. Even when a community does all the work to establish treatment, it's not long after the detainee is released that he or she encounters a child welfare worker or a judge or a probation officer who says, yeah, you're on methadone, you're not clean, you can't ABC, you can't be in our drug program, drug court, you can't live in this place, you can't have your children back. So it hurts the person who is in fact in stable recovery, in a position where they have to decide whether to terminate the medication that's keeping them in stable recovery or not. And what we learned is that that really puts people at risk for overdose, for relapse and overdose and death. And so our SOR program in California started a whole second program around educating all of the professionals in the justice system about opioid use disorder, the medications and its treatment, and specifically by profession, their role in keeping their clients stable by keeping them on their MAT treatment. We've trained over 1,600 people in California. And most importantly for you, we have converted all of our training into web-based modules, and each one has a facilitator's guide with it. And the whole thing was designed so that people could use it outside of California or inside of California to train their own employees. All this material is free and it's on our website. Do not underestimate this issue. California is the only state that's really broadly addressing the public or the professionals in the justice system that often place restrictions or urge their clients to discontinue their MAT. So it's really important to make sure that you're closing the loop on all of the people that are going to have contact with these clients. So in summary, people with addictions in the justice system are a priority population for any community. Treating their addictions in the justice system gives them a chance to recover. And these are people who are suffering from the most advanced addictions. It gives them a chance to recover and get their lives back. It reduces relapse, overdose, and death, and it reduces crime. It can be challenging, but it is essential. Withdrawal management and addiction treatment are clearly defined conditions protected by the Americans with Disabilities Act, and all of the decisions about medications for addiction belong under the authority of healthcare in a correctional setting and in the confines of the patient and prescriber relationship. Opioid use disorder treatment that is in place when a person enters the jail must be continued, and until after release, until the provider and the patient decide to taper it. This takes a village. This saves lives. And I'm going to give you a slide that has information about our Jail MAT project website with some really cool, good, recently done webinars that you may access, and also to all of our training materials for the justice system. Thank you very much for your time today. Go forth and do this work. It saves lives.
Welcome to our Fireside chat on accelerating health philanthropy to address the opioid crisis. I am Karen Scott, President of the Foundation for Opioid Response Efforts, or FOR, and I'm joined by my colleague and Senior Program Officer, Ken Schatzkes. We will take the next few minutes to reflect on what we've learned in our first year of grant making, the impact of COVID-19, and the opportunities ahead for FOR and other foundations to impact the opioid crisis. FOR was launched 2 years ago as a brand new private national grant-making foundation focused on supporting and accelerating solutions to the opioid crisis. We have set our mission as convening and supporting partners to advance patient-centered, evidence-based solutions. And we focus along 4 particular themes: provider education, payer strategies, policy initiatives, and public awareness. 2020 was our first year of grant making, and I am thrilled with our progress. We now have 34 grants and 32 organizations in many parts of the country. Our first program area focused on projects to improve access to treatment for vulnerable populations. And that was followed by a focus on recovery support services and projects on policy analysis and evaluation. And those last 2 areas have really been very much developed and reflect the needs that we were hearing about as pressing needs during the COVID pandemic. And with that, I want to turn to Ken and begin our conversation. And Ken, as we reflect on our first year of grant making, what are 2 or 3 lessons, big lessons for you from this past year?
Thanks, Karen. Well, it's certainly been an inspiring year of listening and learning from all the organizations that have reached out to us. And one of those ways we learned was through our inaugural request for proposals that focused around expanding access to treatment for vulnerable populations. We received over 450 applications from organizations located in nearly every state in the nation. And because of that incredible response, we were able to quickly get a deep grasp on what is happening on the ground. In terms of takeaways, the first and maybe the most pressing that we saw was that even though medications for opioid use disorder are an evidence-based best practice, they are still not being used nearly widely enough across the country. A second related takeaway is still a lack of, quote, meeting people where they are. Whether a person presents in a primary care office, an emergency room, or even a homeless shelter, it's important that we are providing people, when they are ready, multiple access points to treatment. The last item I'll mention that we saw in many of our RFP applications were requests for staffing to either start up or continue services. Much more attention needs to be put on training and expanding the addiction workforce, including waivered providers and peer recovery coaches, all to expand access to treatment across the country. But how about you, Karen? What are your big lessons learned this year?
Thanks, Ken. And I absolutely agree that our RFPs have been a tremendous learning opportunity for us in and of themselves. I would first add to your last point on workforce. The limited workforce around the country, particularly for vulnerable populations, extends beyond addiction-trained staff. In many areas, we saw a lack of any behavioral health capacity. So building core infrastructure and finding creative ways to meet staffing needs, particularly in rural and remote areas, is certainly an ongoing pressing need. In addition to your points, though, I would add health equity as even a more significant aspect of our work than I imagined. A number of our grantees are contributing a greater understanding of racial disparities in opioid use disorder, access to treatment, as well as disparities in who is engaging in recovery services. We know that rates of OUD, overdose mortality, have rapidly escalated for Black and Latinx populations in the past 3 or 4 years, as the types of opioids in communities has become even more lethal. Yet we also know that access to treatment lags that available into the general population of white patients with OUD. And in part, that's due to a long-standing tracking of minority populations to particular treatment services, particularly a focus on the methadone and opioid treatment programs with stricter requirements. As we look at models for improving access to treatment, improving access to all forms of medication for opioid use disorder in a range of settings and reducing barriers means also recognizing and addressing these racial disparities. Finally, our focus on vulnerable populations has really been reinforced. The feedback and responses to our webinars and RFPs very much support our continued focus on those at highest risk, including pregnant and parenting women, those involved with the criminal justice system, homeless populations, and adolescents and young adults, as well as people of color. Truly making progress will require shaping solutions to all of these populations.
So we awarded, the access to treatment grants at the beginning of March, just as another crisis was beginning to brew, the elephant in the room, the COVID-19 pandemic. And responding to COVID, really forced us to pivot our program plans to focus on maintaining recovery support services during the pandemic and more policy evaluation projects. So how do you think the response to COVID will continue to shape FOR's work into the next year?
Thanks, Ken. And back in June, in fact, I wrote a piece in GrantWatch about the important role FOR and other foundations can take in making sure we learn from changes during the pandemic. And I continue to see many opportunities for us to do so. There are many, in fact, natural experiments for us to learn from, which can in turn inform longer-term policies and systems improvement. These, of course, include the temporary increased flexibility in the use of telehealth and temporary relaxation in some prescribing and monitoring requirements. There are also care delivery innovations, such as those related to telehealth and use of other technology. And we're beginning to see a great heterogeneity of experiences with these changes. And those differences are based upon the provider type, the patient population, the parts of the country and state level policies enacted, and indeed simply over time as the pandemic wears on. So the learning opportunities are significant and strong, and timely data collection and excellent evaluation is vital. Ken, what's been the impact of COVID on our projects?
I think, the pandemic has brought new challenges and has also magnified already persistent issues related to the opioid crisis. Our inaugural grantees that were awarded in March, they had to adjust their projects to be successful in COVID-safe environments. But I have been incredibly impressed with their flexible, quick, and innovative thinking in responding to these new challenges. When it came to awarding new projects that were specifically responding to the pandemic, we saw a great need to focus on innovative virtual recovery support services, particularly for vulnerable populations, as stay-at-home orders and social distancing measures were put in place. So I can give three examples of grantees doing this. One is Ballot Health, which quickly expanded their virtual recovery services and warm line, staffed by peer recovery coaches, in 29 counties in rural Appalachia, Tennessee, and Virginia, all to ensure people stay connected during the pandemic. Another is the Addiction Policy Forum, who is partnering with drug courts and drug diversion programs across the country to provide free access to its Connections mobile app, which offers on-demand treatment and supports from addiction specialists and peers. Incredibly, they have already received requests for 6,000 individuals for 1,000 spots, an indication of the high degree of unmet need for this vulnerable population. The final example I'll give involves the resulting uncertainty on college campuses today that is stopping students in recovery from being able to participate in their collegiate recovery programs. Our grantee, the Association of Recovery in Higher Education, is helping to reduce these barriers through offering webinars, virtual recovery meetings, and professional development opportunities, all to keep students connected to their recovery communities throughout the pandemic. So I'd say it's been an incredible first full year for FOR. But as we look ahead, Karen, what is one challenge emerging or neglected that you hope at Philanthropy, along with public health officials and policymakers, that we take on in the next year?
Thanks, Ken. And so unfortunately, there are a number. The reality is that we are likely to be faced with an even greater opioid-related crisis in 2021 than in the past couple of years as we've started up the foundation. And that's based on given the reports that we're hearing from around the country on the increases of overdoses and overdose mortality during the pandemic. But my sense is that while we are somewhat on track in terms of policies and programs to improve access to treatment, the prevention and recovery ends of the continuum are less clear. And I would say a good challenge for us to take on is striving towards a better understanding, or perhaps a recasting of how we think about prevention and recovery. Indeed, it seems to me that very often we're talking about some of the same tools and capacity for both prevention and recovery, such as family and community supports and opportunities for education and jobs. Continuing to build an evidence base for prevention and recovery, what works and for whom, should be part of our next steps. And hopefully that will be in partnership with many of the organizations included in the summit this week. Ken, how about for you? What challenge would you like to highlight?
Well, building off of your mention of the evidence base, the one challenge that comes to the forefront, no pun intended, and that I've been thinking about for a long while is around data and timeliness. And the backdrop of the COVID-19 pandemic actually provides a perfect example of how lacking the data infrastructure is in responding to the opioid crisis. While there are systems in place to deliver real-time data on infectious disease outbreaks, we are still often waiting an entire year before we have final numbers on, for example, fatal overdoses. Responding to a public health crisis is already challenging, but doing so with an incomplete picture of the current situation essentially forces us to respond based on what could be past assumptions. This has implications across the board, including in funding decisions, policymaking, and delivering care to patients. We need to provide more opportunities to integrate different data systems and sources, capturing different aspects of the opioid crisis, all in order to build an infrastructure that can give us deeper metrics, be closer to real time, and allow us to better respond to the crisis based on the data.
Great. Ken, thank you. Very well said. Innovation in data and how we look at data itself. Thank you all for joining us. We hope that this has been helpful in introducing the 4 Foundation, and that many of you will reach out to us for more discussion in the coming weeks and months. Thank you and take care.
Thank you.
I'm pleased to bring in our next panelist. We're going to be talking about why technology matters, how technology helps us understand the evolution of opioid outbreaks and patterns of opioid use, along with the systemic and ethical considerations related to using these technologies. Our moderator today is Sonia Angel. Dr. Angel is an assistant clinical professor of medicine at Columbia University, and she's the former director and state public health officer of the California Department of Health. And joining Sonia today is going to be Dr. Zaniello, Chief Medical Officer of the Collective Medical Technologies, as well as Shannon Biello, Director of the National Treatment of Quality Initiatives at Shatterproof. It's a really exciting panel. Thank you so much.
Great, thank you so much for that introduction. It's really a thrill to join you all today, wherever you are across the country, as well as 2 really top presenters that we have. I'm excited to introduce them to talk about why technology matters. You're going to see some really interesting contrasts. First of all, whoever was able to come up and find these 2 people with the same almost last names, Dr. Biello and Zaniello, I think that's terrific. On top of that, they really bring some remarkable expertise that complements one another in this discussion. So first of all, Dr. Biello will be presenting a product that really focuses on individuals and clinicians, and really brings that perspective from the community and the providers themselves into the conversation, contrasted with Dr. Zaniello's product, which we'll be talking about, which is really about networking systems that focus more directly on the providers as they provide direct care, as well as exchanging information across systems. And I think together they give us a really good understanding of some of the technology that's out there, and we can have a very robust conversation around it. So without further ado, I'm going to go ahead and introduce Dr. Zaniello first. Talk about it, and we'll move on. So we'll have 2 presentations back to back and then have time for discussion. So let me turn it over to you, Dr. Zaniello.
Howdy, thank you. And obviously I love being here, so I appreciate it. And I will try desperately to provide a point of view that goes beyond the Italian-American view on the opioid epidemic and technology given our similar last names, it may seem we're limited in that regard, but I promise you we're not. So going into our first slide is the why technology matters aspect. And I'm a practicing physician, and what I've learned most in my practice in emergency rooms, in hospitals, and other care facilities is that so often medical decision-making is focused on ferreting out medical uncertainty instead of medical necessity. And I think in particular with the opioid epidemic, that gap is one of the biggest drivers to our problems today. So I'm not sure a slide is up. I can't tell actually if a slide is up, but assuming we're on this slide that gives you an idea of the emergency room trackboard. So a big piece of the emergency room trackboard is essentially, and for those of you that don't live within the emergency room, and that's probably a good thing if you don't know it particularly well, but essentially that you see the patient name and information, what room they're in, their nursing staff, the assigned physician. That is essentially where emergency room physicians and their staff live most of their working lives in pulling data out of that. And unfortunately, generally speaking, in an emergency room transaction, there is that single transaction essentially where they have to, in a very short and punctuated period of time, understand why you're there and treat that specific illness. Now, the problem with that, of course, is that as a patient, your care is not focused on that single moment. It's in fact in a continuum of care. And what we do first and foremost as a company is bring more information to that care decision-making process. And if you see on the right side of the slide, you'll essentially see the type of information that is critical to that care paradigm. So information about past encounters, past diagnosis information. If your state has a controlled substance database, your history of controlled substances, all the things that would allow the provider to focus on your needs and not necessarily on ordering as many labs or tests available to reduce their risk. And I think that's really an important distinction here, and particularly important in the opioid epidemic, where so often we've been focused on that medical uncertainty piece and worried about, say, drug-seeking behavior, when in fact, the number one priority should be bringing someone out of pain, and their pain potentially could be based on a history of cancer treatment. It could be based on a chronic back illness for which another provider has put together a care plan. And by being on our system, you have that care plan in front of you and can treat them appropriately as the care continuum dictates. Let's go to the next slide and give you a little bit of idea why this is particularly important. This speaks to the wider care continuum. So what we're seeing on this slide is essentially two areas. So on the left is the state of New Mexico, and the right is the Pacific Northwest. The blue lines are a patient moving from one care facility. In this case, I just focused in on hospitals. Otherwise, you wouldn't be able to differentiate anything from one hospital to another in a period of time, less than a year in this case. The green lines are the intra-state movement. So moving from one hospital within New Mexico to another, or within Oregon to another hospital in Oregon. This is over a year period. All those lines represent patient movement. So this is critical to connecting the care continuum. Knowing that through our data that your patients, for example, all those lines stretching from Seattle into the abyss, no offense to Alaska, they are actually heading to Alaska. So in a calendar year, thousands of patients in the Pacific Northwest and frankly around the country are being seen both in Seattle, Portland, and in Anchorage, Alaska. And it's really important for their care for it to be aligned and to have visibility across that care. And by connecting thousands of hospitals and pushing them into information into workflow, it then becomes critically important. What you're then able to do, and let's go to the next slide, by having that perspective, by gathering that data across these different parts of the care continuum, you start to also gain a population health view of patient movement and patient activity. So here you get a view of, in this particular case, a set of hospitals and the patient movement between those hospitals and MAT clinics, or medication assisted therapy clinics, SUD clinics, or FQHRCs that are managing pain management. You actually get visibility into the patient movement across them. And then importantly, you can start managing at a population health level. For example, you can ask important questions. What interventions are working? What hospital programs are actually bringing people out of the opioid epidemic, and which clinics are successful at capturing that patient and bringing them on a road to recovery, which I think is really exciting. And then finally, just one more slide, just to give you a little bit of an idea of some of the outcomes you can expect when you cross the care continuum and you change care both at the provider and patient level, but also at that population health level. This is just one program I'm going to highlight in New Mexico, whereby a health plan, in this case HCSC, or specifically Blue Cross Blue Shield of New Mexico, working with the provider community, created a program when someone entered the emergency department with worrying behavior, high-risk behavior, and in fact could benefit from a direct intervention at that point. Because it's also critical to note that no physician, no ED physician wants to be a blocker and say, oh, based on your worrisome behavior, we're not going to provide you a narcotic. That may bring the number of prescriptions down, but in fact, it may actually not help that patient, who again is likely in pain and looking for a pathway. So the ED Bridge program, and a program like this, which brings in recovery specialists, people that formerly had opioid use disorder themselves, to directly interact with these patients in real time. So you start the pathway of getting them out of the emergency room, which is an awful place to have your psychiatric or OUD behavioral health illness managed, and bring them into outpatient therapy. So this was just one example. It showed that it can be efficacious. It can decrease the number of people going to emergency rooms for this, and in fact, bring people again on that road to recovery, which I think is particularly exciting. Just one example, but given how awful this epidemic is, particularly in the setting of COVID, I thought it important to end on a positive note and a little bit of where technology can actually help. So back to you all. Thank you.
Great, that was great. Thank you so much. And we'll get back and be able to ask more questions about your product, about the work that you're doing. But we'll pass it over now to Dr. Vaiello for her to share with us an overview of the work that she's doing.
Thank you so much. And I'm assuming it's showing our title slide right now, but my name is Shannon Vaiello. I am the Director of National Treatment Quality Initiatives at Shatterproof. And we'll just provide a very quick overview of Atlas, our platform, and how it uses technology and data to improve addiction treatment quality. Next slide. So a very quick overview of Shatterproof. If you haven't heard of us, we're a national nonprofit dedicated to reversing the addiction crisis in the US. And as part of it, we base our work on these 3 pillars. 1, revolutionizing the treatment system to ensure that all individuals have access to and are able to engage in high quality addiction treatment. Another, breaking down addiction-related stigmas. And a 3rd, supporting and empowering communities, providing educational resources regarding prevention and treatment of addiction, as well as supporting in related policy efforts. Next slide. And as one of our first steps in thinking through how to revolutionize and transform addiction treatment, we wanted to think through how we standardize quality expectations. So one of the first steps Shatterproof took is we worked with a task force of experts and clinicians and other researchers in this space to develop the Shatterproof National Principles of Care. And these 8 core concepts are derived from decades of research in the field, including the landmark 2016 report from the Surgeon General. And they are core concepts and core components of evidence-based addiction treatment that have been shown to improve patient outcomes. And in creating this and releasing it, it was a great first step, but we wanted to make sure that in developing these principles, we made them actionable. So one of the steps we took related to developing the Shatterproof National Principles of Care is we created Atlas, which is a quality measurement system for addiction treatment facilities and measures how well addiction treatment facilities align with these evidence-based best practices. Next slide. So how does Atlas fill this gap? We know that it is challenging for people when searching for addiction treatment to find high quality care. There's predatory marketing practices, there's glossy advertisements. It's a very challenging thing to navigate. Even people in the field struggle at times to find high quality addiction treatment. So we created Atlas to provide transparent indicators of treatment quality. We do this through 3 data sources. We have a treatment facility survey, which the addiction treatment facilities in Atlas states complete and submit to us. We also crowdsource patient feedback from patients who have had care at the addiction treatment facilities. And we've also piloted the use of claims measures. One thing that's important to note about Atlas is that we include all addiction treatment facilities in the states where we implement. And we worked very hard to ensure that we identified all of the addiction treatment facilities within the states by cross-referencing federal and state lists of facilities to make sure that our list was the most comprehensive. Additionally, we are interested and invested in empowering people to navigate to high quality care. So other aspects that we include through our platform are consumer assessment, as well as some educational content that support people and empower people to be informed consumers in this space. And we'll talk about that a little more in a later slide. But I think it's also important to note that this isn't a pay-to-play system. We're including all treatment facilities, asking them the same questions, having them display the same data so that people can use it to navigate to care. Another thing I will note is that we completed and built Atlas after rigorous user testing, and we engaged all different users in this process. Of course, there's the consumers who will use the platform to search for and compare addiction treatment facilities, but then we're also engaging providers, state agencies, and payers through password-protected professional portals that provide them with customizable dashboards or customized dashboards, information that they can use to look at addiction treatment quality at multiple levels. Next slide. Okay, and this is a very brief overview of Atlas Phase 1. We actually have just completed Phase 1 and are on the way to Phase 2, so it's a very exciting time for our project. Atlas was a $5 million pilot funded by Arnold Ventures, the Robert Wood Johnson Foundation, and a coalition of health plans. And we are, in Phase 1, we were in 6 states. They're listed here, but it's Delaware, Louisiana, Massachusetts, New York, North Carolina, and West Virginia. And in the process of implementing in Phase 1, we of course identified and tested our set of measures. We participated in a robust state engagement plan, which included the convening of a state advisory committee and other activities. We collected and analyzed the data, and we launched our platform, built and launched treatmentatlas.org, and it was made available in July of 2020. So exciting times. Next slide. And this is our homepage. So when you go to treatmentatlas.org, and I encourage you to do so at your own leisure, perhaps now on your phone, this is what you'll see. So you'll see immediately there are 2 options that someone can take. If you're ready to search for care, you're ready to input your location information, perhaps your insurance information as well, you can do so. You can begin your search and you'll be taken to your search results page where you can begin to look through the information on facilities. But if you're new to this space, if you're not sure where to start in the search for addiction treatment, you can take the assessment. Next slide. And the addiction treatment needs assessment is a set of 13 anonymous questions that a person can complete for themselves or their loved ones, and they assess a person's risk and severity, and ultimately from responses generate a treatment recommendation and recommendations for some additional services, whether it's mental health care or medication for opioid use disorder, that a person should look for in their search for addiction treatment. This, of course, is not meant to replace a formal clinical assessment, but is meant to be a means to support one in the first few steps of searching for care. Next slide. So what's good about the addiction treatment needs assessment is that if you get certain recommendations, if you receive a treatment type recommendation, say outpatient residential, we'll pre-populate that into your search results. And we'll also pre-populate the additional services that may have been recommended to you. So you get a customized listing of search results. You can, of course, use the additional filters. We have a number of filters included on the site to search for care. If something like one-on-one counseling is important to you, you can select that filter, or you can deselect filters to make sure that you have a listing of treatment facilities that meet your specific needs. Now, here is a treatment facility profile. You'll see at the top, we include descriptive information about the facility. So when you're in your search results, you select a profile, this is where you're taken. You'll have the listing of descriptive information. We have some additional information listed that's not on the slide, like payment options, age-specific programming, and then we have the quality measures, which you'll notice are organized by the Shatterproof principles of care. And here we simplified this display so people are able to look at services available through the facility as quickly as possible to make their decision. So you'll see we use green check marks, red X's, iconography that people are familiar with and can recognize and understand what's meant so that they can easily search through care. If you're a person who's interested in the details, I know I always am, you can collect the See More part, and it will include a drop down with additional details about other things like the like medications for opioid use disorder, so that you can really drill down into what's available at the facility. What's shown below this signs of high quality care section are patient feedback. And how we display that is we show the frequencies of responses to the multiple choice items. These are survey items derived from CAPS and ECHO questions, so questions that are used to assess consumer experiences of care. And we also include one open-ended text response. So you'll have the frequency of survey responses. We display them next to state averages, so you can kind of benchmark how the facility is performing in terms of patient feedback. And then you'll also have the narrative reviews displayed. So you can also see how people are responding and providing feedback through that open text response. And this aligns with what we're seeing in consumers in their search for care. They want to hear the ratings and reviews of their peers. So we wanted to provide this to them. But we provide it through validated survey questions, and we only display responses once we have 20 patient submissions for a facility. So I wanted to end, next slide, with, of course, the data. Yes. So Atlas Phase 1 data was very exciting. We were very pleased that 51% of facilities submitted data in the first round of data collection. That was a period from October to January. Really great results. We also had 8,600 patients submitted feedback within that window. It was an October to March window. We ended early to be cognizant of providers in COVID and the challenges they were facing, because they were very supportive in the process of collecting patient feedback. But what we found with our analysis of the Phase 1 data is that the data do demonstrate differences in care across facilities, states, and levels of care that can be used to explore facility performance. Think about how we make data-driven improvements, whether at the facility level using their data to see where there are opportunities to improve their services, or through state agencies thinking about how they optimize the resources that they provide to their treatment providers. There's also a great opportunities to think about how we drive innovations in the space. By providing this information to states and payers, we can think about how we implement models that could be used to advance the use of clinical best practices, thinking about things like value-based care. And I want to end with, giving a big thanks to all the people who have supported us on the project. It's a multi-stakeholder project, so working with our state agency partners and the providers and others. So a big thanks to them, and happy to answer questions.
Great, thank you so much for that presentation. Very interesting to hear about all of the ways in which you've customized ways so that people can get the care that they're looking for at the moment that they need it. So I'd like to invite the audience now to submit any questions that you might have. We're happy to take them. And in the meantime, I might just kick us off with a question that I think sort of speaks to this moment, which is if you could both talk from the perspective of your technologies as well as your knowledge of the field. How can these types of technologies that you have, which are distinctly different but clearly complement one another, how can they really help us understand the patterns of opioid use and help us be proactive then in about responding to the needs of our communities in really addressing this issue? Ben, I'll just hand it over to you first. I'd love to hear your thoughts on that.
Sure. I mean, I'm probably going to sound a little bit like a broken record, but what I'm struck by working in a variety of care settings is just there is great work happening in clinics, in hospitals, in emergency rooms, in all these different care settings. And this is an opportunity, and via regulation, by good work by Shannon's company, which I love what they're doing, is to essentially get the data out there and share it so that, one, we can understand what are the good interventions and what works well, and then importantly, what has already been done. And that's a big piece for me. This is where technology, and there's the buzzword of interoperability, which is fine as long as we focus on what interoperability will bring us, and interoperability should bring us that care providers just have more data about the patient that they're seeing so that they can essentially bring forward whatever work had been done before and not just spend their time being desperate, which is the current state of how we treat most patients with OUD.
Great, thanks.
Yeah.
Shannon,
Oh, sorry, Sonia. I would add to that. I think that Ben correctly identified that what we see value in is the data. And when I think about things like the opioid epidemic, what data allow us to see are looking at those specific areas that need attention. So by looking at the treatment landscape in states, we're able to see where best practices are being applied at the facility level versus not. And we give people the information they need to design solutions that are tailored to those contexts and landscapes, like giving states the opportunity to see where their treatment gaps are and to design solutions and optimize resources so that they're targeting areas where they can have the most impact and actually drive the use of evidence-based practices in addiction treatment. And part of that is looking at the services that are available and seeing how we increase the use of those services or optimize the use of those services at the facility level.
Great. So we're able to create this sort of broader picture of what's happening, what the real infrastructure is to be able to respond to this at any one point or time. We got a question that came in for our audience, so I might put it out there. And this question is specifically for you, Shannon. They're asking how the states for the treatment atlas were selected, and then what are your plans to expand to other states? So really interesting.
We love this question, and I don't think I mentioned it during my presentation because I wanted to make sure we leave time for questions. But Atlas is poised for expansion in 2021, which is why I say it's a very exciting time for this project. Very exciting, very busy. We selected states in phase 1 through an RFP process. So there was an application, states applied. And the way that we arrived at the phase 1 states is we wanted a mix. We wanted different contexts and landscapes, a mix of urban versus rural, a mix of different regulations and policies, Medicaid expansion versus not. And that allowed us to really, in phase 1, the intent was to really demonstrate proof of concept, right? We wanted to show that Atlas could work in different state landscapes and contexts. And I think the success of that is really attributable to the multi-stakeholder approach. We work directly with our state partners. We engage in state advisory committees. Those are not just composed of traditional leaders in the addiction treatment space, but it's recovery advocates and community-based organizations. So everyone's in the space and everyone's giving us perspectives and feedback on how Atlas best fits the landscape of the state, whether it's the Delaware, the Massachusetts, Louisiana, all of our states. So that approach was really critical. We, again, really wanted to make sure that we had a mix of different state landscapes and contexts. And I think that led to the decision in the 6 states. And of course, I will mention, I would be remiss if I didn't say that if you're interested in Atlas being in your state, you can email me. My email is Biello at shatterproof.org. We're always happy to have those conversations and discuss how it makes sense and when it would make sense for your state to be included. So
great, that's helpful. That's helpful for you to share yourself as a resource to folks that are tuning.
I know. I'm worried about my inbox.
Well, yeah, that you should worry. I think one of the things that you did bring up that I think is so key, and we've sort of talked about also, is this opportunity to engage multi-stakeholders in this in a really meaningful way. And so, Ben, I might turn it over to you to ask you a little bit about your thoughts on that and how your product and sort of extensions of your product might really help bring all of the key players into this in ways that can be really game-changing.
Yeah, I think one kind of critical aspect of this is that mandate and other ways, regulation that we've kind of brought forth participation has not always been effective in the past. And again, I love what Shannon was talking about, which is creating a pilot project to show efficacy so that people stand up and say, I really want to be a part of this because it matters. And philosophically, that's how we approach our customers and our customer base and state and regions in general, which is ensuring that they are driving value through our connectivity, that it is not someone producing data for someone else to use, giving access to their medical records so that other people can derive value from it, that it really has to be a shared community effort where everyone is getting to participate, put effort in, but also draw value out of. And I think that a little bit that mindset has been unusual, particularly, frankly, in healthcare technology, where there were regulations that created the medical records that then hospitals and everybody were told to use with, I think we've now recognized, fairly mixed results. So this new paradigm whereby you do it at a community level, you bring in experts from different fields, you bring in community members, you bring in patients, and they all work together deciding what are the priorities, who to bring on, what value will they get out of it, I think is really great. So I feel like I'm just echoing what Shannon said, but I thought it was great.
Well, I think this is an important point too. And we just had another question related to health disparities come in that I just like to build upon as well, because I think those comments that you're both making about multi-stakeholder engagement is sort of a bare necessity to be able to ensure that the products that we design actually reflect the needs of the individuals being affected. And that becomes important, critically important, when we talk about communities of color and other communities that may be disadvantaged, disempowered, or experiencing the stigma in different ways. And so I wondered if you might speak to how these platforms or technologies help address some of the issues and help create solutions for closing these gaps that are perpetuated throughout these systems at times. And then not only how can we close them, but maybe tell us something about where might be some of the risks for widening gaps through these technologies, so that we can be more thoughtful as we build forward. Maybe I'll go to you, Shannon, first, and then back to you, Ben.
Okay. Yeah, so I think one of the things that I think about when considering how technology addresses gaps is what Ben brought up at the beginning, which is the democratization of data. And that can exist among the professional networks, but it also exists when we make data available to the community, the public at large. So we're saying, traditionally people who may be more familiar with the healthcare system may be able to more easily navigate to care, especially in the addiction treatment space. And by providing and democratizing data in a public-facing free platform, we are hopefully giving and empowering people who may not traditionally be engaged in care the opportunity to understand and be an informed consumer in this space. So that's one way I see it. However, and there's always a however, have to continue to first, and this is something we did through Atlas, test the platform to be sure that it's meeting consumer needs. And that's anything from functional testing to language testing. With Atlas, we had to be very intentional with our language, because addiction is a jargony field. And if it's your first time in this space, it can be really overwhelming to understand what is being communicated to you. So that involves things like usability and cognitive testing to ensure that the resource would meet the needs of our consumers. But there's more work to be done. You always, when you release a platform, and I can speak to this as well, as it's always a version, and the version can be improved. And what we see is, and what we get from having such rich relationships with our stakeholders, is we're able to get feedback that will continue to enhance the platform and allow us to think through things related to accessibility and create a resource that isn't suited to very specific populations, but suited to as many people as possible, because that at the end of the day is what we're trying to serve, everyone. So those are some of the ways in which I see technology being supportive of addressing inequities, especially through data, but with the caveat that we always have to continue to think about the ways that we iterate and improve upon platforms so that they're reaching those that are most vulnerable, who may not traditionally engage in addiction treatment.
Great, thanks. Excuse me, Ben, your thoughts?
Yeah, clearly Shannon and I are in a bit of a mind meld here, because I, again, agree with everything she said. From the data perspective, I think it's really interesting, because one of the ironies around the opioid epidemic from a data perspective was that initially, and certainly how we practice, was we had certain ideas about who had opioid use disorder. If you framed it up in the emergency room, there would be certain implicit and frankly explicit bias about who was presenting with OUD. Of course, now that we've finally accessed the data and spent some time on it, and there's been great research on this, we recognize that some of your classic stereotypes of addiction have changed radically. And for example, the example I always use, and I'm not picking on the women on this call, but your mother of 3 that is on her way back from soccer practice that's asking for a narcotic for her migraine is actually in a higher risk demographic for OUD than, say, your truck driver who's coming in with chronic back pain. And that's been a big shift in a little bit our mentality of how to treat it. Now, of course, maybe the worm has turned a little bit, and now we have better idea of who is in that high risk category. And we are now recognizing that there are whole communities, as Shannon put it, that didn't factor into that data because that they weren't studied, or that we basically didn't understand their needs. And I'm thinking of even disease patterns like sickle cell anemia and how we manage it today. But you also said something that I thought was really interesting, and I think goes to the kind of question of kind of moving forward, which is in the setting of COVID-19, and obviously we couldn't have a 40-minute discussion on anything today as we all sit in our individual homes watching this and talking about this in the setting of COVID-19, is how that has affected the opioid use disorder from a health equity perspective. Generally speaking, if you look at a gross level, mental behavioral health and opioid use disorder, substance use disorder, has been underfunded and undersupported in healthcare due to stigma, due to privacy reasons. There are many reasons. And of course, COVID-19 from a health equity perspective has just accelerated that, given the natural isolation of the disease and the limited treatment services. And then you start telling people, well, you shouldn't go to the hospital anyway, no matter what, because of COVID-19. So I think we're all aware of that, particularly this kind of, I'm preaching to the converted here, but it's certainly fascinating and disturbing what's happened recently in that setting.
I would imagine the types of technology that you have allows you to track when somebody isn't showing up who should be coming in, and creates opportunities for providers to create panels of their own patients, to look through those panels and to understand who may have sort of fallen off the grid for some time and that needs some special reaching out to as a part of a response to that. And I think what you bring up around COVID is also interesting, because now we're dealing with these pandemics, epidemics in the United States, and just sort of thinking about how and what kinds of barriers might exist to people being able to seek care in ways that is most effective in this context, as we have people not being encouraged to seek care in general, and wondering how technology can work further on that issue. Do you have additional thoughts on that? Other barriers that might exist?
I think both of us have a lot to say on that issue.
No,
in our last
it's
couple
huge.
minutes.
We've got about 6 minutes left, Shannon.
Shannon,
Give us a couple thoughts on that.
The thing I will say, and we don't collect patient level data. Obviously, we're at the facility, so we're thinking about the delivery of care, right? But I will say, it's a very interesting time. We saw Atlas as a resource that's examining brick and mortar facilities, and that's traditionally where people were receiving care. We enter into this pandemic phase, and all of a sudden, the treatment landscape has changed. Providers, in response to COVID and the restrictions that come with that and in-person treatment, have to adjust the ways in which they provide care, whether it's a physical facility site offering additional telehealth services, or it's the provision of telehealth only. And I think it's a really interesting time in addiction treatment, and certainly the explosion that we've seen in telehealth will be around. And so from our perspective, it's thinking through the ways in which we can look at the telehealth that's available and continue to assess quality to ensure that even with these different treatment modalities, people are still able to have improved patient health outcomes. And so it's being flexible within the space and understanding how we can continue to measure and assess addiction treatment to ensure that patients are being served.
Great. Your thoughts, Ben?
Yeah, I mean, it's funny. I was trained as an infectious disease doc, and I used to view telehealth suspiciously as an antibiotic delivery vehicle for viral sinusitis. And I've totally changed. I now love telehealth and have been working with many telehealth vendors to essentially move from what it still is, which is mainly reactive, to Sonia, what you talked about before, which is being proactive. So identifying the patients at risk and reaching out to them essentially such that they don't have to be proactive themselves, which is already incredibly high bar in mental behavioral health. So I think that kind of growth is really important. The plug that I would put in, of course, is that from a health plan perspective, from a government reimbursement perspective, it's so critical that we get telehealth to the point where it is a fine work for all sorts of professionals at the top of their license, because it's certainly really the only way we're going to be able to manage ourselves from a healthcare perspective out of COVID-19, and then even ongoing from a quality and cost perspective in healthcare. So yes, I mean, I will not disparage telehealth ever again.
Well, listen, we have just a few minutes left. Maybe give you both a minute, just based off your last comment about telehealth and its importance. We have a new administration coming into at a national level and across the United States. It creates other opportunities to think about the way that government might engage to help support this move forward. Do you have any wishes that could really be game changers in this? And Shannon, maybe you can go first.
I think from a policy perspective and the way that we look at things, it's adapting practices and being flexible to adapt practices that we've seen in the past few years or decades are shown to help patients. And in our work, we think about things like coordinated care models. We think about now this inclusion of telehealth. So it's continuing to think through the ways in which we can expand policies related to addiction treatment to support the evidence base for new treatment and the ways that we can adopt these practices into the addiction treatment healthcare.
Great. And your final thoughts then?
COVID-19 is obviously, the pandemic is awful, but it's certainly a wake-up call. It has exposed our issues in public health, and in particular in the opioid epidemic. So let's listen, right? Let's create the facilities. Let's increase access. Let's make a better safety net, or even better, not need the safety net. So I am cautiously optimistic.
Great. Well, listen, I want to thank you both for your time, for sharing with us your insight. Really wonderful discussion. I appreciate the audience sharing your questions. We hope this was a good use of your last 45 minutes, and we're looking forward to the next session. So thank you very much for joining us.